guys, I'm Siobhan, an internal medicine and rheumatology specialist. For those of you who don't know Dr. Glaucomflecken, he's an ophthalmologist in the US who makes these really funny videos that make fun of different medical specialties, but in such a clever way that it just gets me every time. Alright, so today we're gonna watch the rheumatology ones. Okay, first day of rheumatology.
Knock knock, hi, I'm the new med student. It's new journal day. Cool. Any good articles? Yeah, they just discovered a new cytokine. Oh, what does it do? Same thing all cytokines do, confuse med students.
Okay, I do not want to admit how many hours I've spent studying cytokines. They're basically these tiny proteins that control inflammation in your body. It's basically the way that your immune cells communicate with each other.
Today is my first day. Well, welcome to rheumatology. We have a great mix of inpatient medicine, outpatient medicine, and waiting on hold with insurance companies to get prior authorizations. Hey doc, sorry to bother.
Oh man, so true. Although a little bit different in the US where he practices versus here in Canada. But basically what he's getting at is that we treat people with very expensive medications. So in general, we're trying to suppress an overactive immune system with our treatments. And these biologic drugs allow us to target specific cytokines that are driving a disease process. They're really cool, they work well, and they're expensive. Like $10,000 to $30,000 per year. And a lot of patients that I treat are on these medications for decades, if not for the rest of their life. If you live in the US, you might have even seen some ads for them. Things like Humira or Enbrel. These are medications to treat rheumatoid arthritis or psoriasis. But fun fact, if you live in Canada, you've never seen one of those ads because it's actually illegal to advertise prescription drugs. I think the most expensive drug that we ever prescribe in rheumatology is eculizumab. And yes, they all have kind of crazy names like that. And it goes for about $700,000 per year. Like, it's just an unimaginable amount of money. So it's our job to convince whoever is paying for this that the patient needs it and that they should pay. And that means paperwork. But I bet some of you are about to say, but you live in Canada. Isn't healthcare free? Well, we have universal healthcare in Canada, and that includes covering most medications if you're under 25 or over 65, but if you fall in between, you're kind of in a tough spot. Yes, you can apply for some government funding, which means more paperwork, or you have private insurance.
Hey doc, sorry to bother you, I have a consult for you. Oh, hey Bill, come on in, what do you got? I have a very interesting patient who... Bill, there's a history of joint pain. Bill... I ordered an unnecessary ANA and now it's positive and I don't know what to do. There it is.
Oh my gosh, drama over an ANA test. That's real. So an ANA is an anti-nuclear antibody test. You know, antibodies normally attack bacteria and viruses, but in an autoimmune disease, the antibodies will actually attack the body's own cells. So in an ANA test, someone literally looks under the microscope to see if there are antibodies in the nucleus. They can see what the pattern looks like in the nucleus, if there's a large amount or small amount of antibodies, but that's it. It doesn't actually tell you if someone has a disease. So it's like if I told you I live in Canada and you were like, so you live in Moose Factory. Well, no, I mean, some people live in Moose Factory, but most people don't. It's the same thing with the ANA. It's like a lot of people can have a low positive ANA, but very few of them actually have a disease associated with it. And I cannot tell you how many times I've had someone come into the office super anxious because someone told them that they have lupus because their ANA is positive. And that's just not how it works to diagnose lupus or any other disease. So basically what Dr. Glaucomflecken is getting at, which clearly is a topic that rheumatologists are extremely passionate about, is that sometimes when doctors don't really know what's going on, they'll just order everything and see what comes back. And that includes an ANA. And sometimes that's the right thing to do, but often it leads to a rheumatology consult where you're kind of like, we don't know why we ordered this ANA and we don't really know what it means, please help. Okay, let's keep going.
You help? Yeah, I'll help you, Bill. But you need to say it. Do I have to? Yeah. Who's your daddy, Bill?
Oh.
Rheumatology's my daddy. Yes, it is.
I don't know, this feels icky. I don't like it. I don't think any rheumatologist is ever gonna make another physician feel badly for ordering an ANA. Or they shouldn't anyway. I don't think any of my colleagues would do that. I mean, at the end of the day, I would way rather spend time reassuring a patient that they have a positive ANA, but they're okay, rather than miss something like lupus because a doctor was too nervous to order an ANA because their rheumatologist is going to be angry with them. I actually did a video with a man named Mustafa whose diagnosis of lupus was delayed for multiple reasons, but if someone had ordered that ANA, maybe it wouldn't have happened. It's a fascinating story with a really positive outcome, so you should definitely watch it if you want to know what lupus is really like. Sometimes it does happen, sometimes it is lupus. Okay, next up, how to ace your rheumatology interview. That was just a few years ago for me.
Good morning, sir. You ready for me? Yes, please, come in. Have a seat. It's nice to meet you. Ah, I see you brought a journal. Very nice. Yes, would you like one?
Okay, I definitely never brought a journal to an interview. That's a new one.
Journal of Rheumatology, August 2018. Ooh, a classic. But no, I brought my own, thank you. I never leave home without a journal. Of course, you never know when a journal club could happen. Surprise journal club. That's how I met my wife.
Surprise journal club. Okay, journal clubs really are a thing, but they're never surprise. So journal clubs are when we all get together and talk about some new trials that came out, new publications. It's sort of like a book club, but less wine, less fun, and a lot more academic. Like you were getting into the nitty gritty to decide if this data, if this research is good quality, and if we can actually apply it to our patient care. And in residency, you have to do a lot of these presentations, and it can be nerve-wracking. I remember this one time when I was an internal medicine resident. I was in the audience, a different resident was presenting, and he was presenting on a big new trial. What he didn't know was the author, one of the main researchers, was in the room at the time, and he was critiquing it. And as he was critiquing it, it's like the room got more and more tense. Luckily, the researcher was great. He made a joke and actually gave some insight into the paper, but like these things can get a little bit tense sometimes. Okay, let's keep going.
We fell in love analyzing a randomized control trial together. She's beautiful.
Oh.
Our wait time at the DMV just flew by that day. Anyway, tell me, why rheumatology?
Okay guys, I don't want to spend this whole time talking about journal clubs, but it's like one of the few times that I actually disagree with Dr. Glaucomflecken about his analysis of a specialty. Like, I don't think that journal clubs and love of journals is at the heart of the rheumatology culture. Don't get me wrong, like we love when a big new trial comes out. It's very exciting, especially because we deal with rare diseases and getting big trials published is difficult. But I think that rheumatologists are much more likely to be talking about a mystery case that they solved, or a rare presentation, or an interesting case. Like, that's what you're gonna hear us talking about more than journals, I think, at least where I trained.
What's your favorite antibody dilution? Oh, 1 to 1600, obviously. Honestly, anything over 1 to 800, I get chills. Oh, I couldn't agree more.
Okay, so here they're getting at the anti-nuclear antibody test, the ANA test. And basically, when there's a higher dilution, it means there's more antibodies present and it's more likely to be associated with a disease. It's true, we do actually get a little bit excited with these really high numbers. Super nerdy.
Why is rheumatology the most difficult specialty? Because there are 1,000 diseases, and they can do anything, at any time, for any reason whatsoever. Yes, like rheumatoid arthritis. I mean, what's it doing in the lungs? There are no joints in the lungs, as far as we know. What is your most...
Oh my gosh, this is my favorite part so far. I love it. That's actually one of the reasons I love being a rheumatologist, because it's about the whole system. It's actually really not just about joints. Like, there's symptoms in the lungs, brain, skin, all of it comes together. It's amazing.
What is your most toxic trait? I always think I can fix autoantibodies. They're just confused. I can change them. I see you have a PhD. What did you study? I spent 5 years of my life trying to answer a single question. Is it lupus? What did you find? No.
Oh.
It's not. Damn. It never is.
Okay, a strong Dr. House reference.
Stash your drugs in a lupus textbook. It's never lupus.
But sometimes it is lupus. Honestly, here's the thing. Once you have spent a day in lupus clinic and you're seeing lupus patients all day, you realize that we have a very skewed perspective. I will say the majority of the time when someone sends you a consult and it's like, is it lupus? It usually isn't. So I'll give him that one. That was so much fun. I also did a reaction video to his internal medicine videos, and honestly, he was spot on. So if you haven't seen that one, check it out next. Huge thank you to Will, Dr. Glaucomflecken, for making this hilarious content and for his permission to use it. Be sure to subscribe, and that way, I'll see you in the next video. So, bye for now.